Good evening, everyone, and thank you for taking the time to tune into our March edition of the BSMS Monthly Lecture Series today. My name is Agatha, and I work in the Admissions and Outreach team at Brighton and Sussex Medical School. Just a bit of housekeeping before we get started. This lecture is being recorded and it will be uploaded to our BSMS Monthly Lecture Series playlist on YouTube, roughly about a fortnight after the talk, once it's been edited and captioned. You won't be captured in the recording. However, if you're not comfortable with the lecture being recorded, we will unfortunately have to ask you to leave the webinar now. Um, if you have any questions throughout the talk, you can submit them via the Q&A function. We'll have roughly 15 minutes at the end of tonight's talk to respond to any questions that you've submitted. If you have any questions pertaining to medical school or getting into medicine, I'll respond to those as we go along through the Q&A function, and any questions related to the talk and its content will be answered by our guest speaker at the end. So now I'll introduce you to our speaker for the evening. So tonight we are joined by Dr. Emma Taylor-Gallardo. Emma is a Specialised Foundation Year Doctor at the Royal Sussex County Hospital in Brighton. She attained her medical degree from Brighton and Sussex Medical School and her master's degree in epidemiology from the University of Oxford. She has interests in medical education, oncology, and general practice. She is currently working on general surgery and has previously worked in haematology and oncology. So thanks so much, Emma, for coming to speak to us tonight, and over to you.
Thank you so much, Agatha. I wanted to say hello to everyone in the webinar. I can see there's currently 203 of you. I love giving talks online and in person. It's really nice to meet all of you. As Agatha said, hi, I'm Emma. I am currently a Foundation Year 1 doctor or a resident doctor at the Royal Sussex County Hospital in Brighton. And this is my talk. So let me just get my slides up. Hopefully you can all see that. I'm really, really happy for you to put any questions that you have down in the Q&A. Agatha can respond to some of them as we go through, and I'm very happy to respond to them at the end of the webinar. So the name of my webinar is Hello, it's the F1, how can I help? Because that's how I pick up my bleeps whenever someone calls me on my own call. So just to tell you a little bit about me, Agatha gave me a bit of an introduction. I'm currently 25. I'm from Brighton. I went to school in Brighton. I did GCSEs, I did some volunteering, and I had a job. All of this in preparation for applying to medical school. I then did my A levels. I did chemistry, biology, and maths with statistics. Then I did further work experience at the hospital. I had a job. I did the BMAT, which they've now got rid of, but I did the UCAT as well. Personal statement, interviews, the whole shebang. It was quite an intense few years. I then did my first 3 years of medical school in Brighton. And I had various jobs. I did a summer research project. I tried to go to conferences. All of this trying to build my portfolio and CV throughout medical school so I could do further training and applications later on. I then took a year out of my medical degree between my third and fourth year, doing something known as intercalation. So, intercalation is where you can take a year out of your degree to do either a bachelor's or a master's. And I went and I did a master's in global health science and epidemiology at Oxford, and it was a lot of fun. And I also had a job through that. And then I came back to medical school in Brighton and I did my fourth and my fifth years, which I really enjoyed and actually I found really brought out kind of what I wanted to do. Yeah, so just talking a bit about life as a resident doctor, I think before you go to medical school, even if you do lots of work experience, even if you've worked in the NHS before, I think it can be really tricky to get an idea of what it's actually like until you do the job. So this picture on the left over here is me on my graduation day, graduating as a doctor with all of my colleagues. And even then I thought, oh, I'm really scared. This is a really big undertaking. And even though I've been to medical school for 5 years and they've told me that I'm ready and I've done all my exams and I've done really well, I'm really scared for what's to come. So at this point, I knew that I was going to have jobs in haematology and oncology. So that's blood and cancer. general surgery, which is any surgery to the abdomen, and geriatrics, so that's care of the elderly. And then next year, I have jobs in respiratory medicine. I have a research job where I'll be in a lab looking at blood cancer. And my last job will be in obstetrics and gynecology, which is women's health and pregnancy and babies, basically. So this is just my ID badge, which I feel like I can't leave and go anywhere without my ID badge. It's like my phone and my ID badge need to be on me at all times, and a pen. As a junior doctor, you always need to have a pen because you need it for everything. You need your phone because everything is on the WhatsApp group chat, or the guidelines are on your phone, and you need your ID badge to get absolutely anywhere. So when I'm walking around the hospital, I'm like, I got my ID badge, my stethoscope, my phone, and my pen. So this is me on the first day as a doctor, as a baby doctor, with one of my closest friends who's also a doctor. We were very, very excited, very nervous, maybe overcompensating. And then I thought that, you know, you kind of hear about when people tell you about stories of patients that really get to you and you get really close to, and when patients say thank you. So this is a photo of me when my first patient said, "Thank you so much, Emma." And they got me a box of celebrations and they wrote a little thank you on the bottom. And I was so emotional, I sat and I cried with her. Um, so I think as doctors, you've got to maintain that professionalism line between they're your patient and you're the doctor. But I think that it's really nice when patients can kind of say thank you and you can show a bit more of that human side with them. And I think on the opposite end of that spectrum, this is me after certifying a death of a patient that I'd also kind of got close to, and you meet their family and you meet them, etc. So it's not an easy job. It's really long hours sometimes. It's really stressful. You're overworked. You're having to make hundreds of, if not thousands of decisions a day. And you're having to deal with real humans' lives, which is a real privilege, but also really tricky. So, I'm currently on general surgery, which, even though I don't want to be a surgeon myself, I find really, really interesting. So, this is an example of what my week on my rota on a week of general surgery might look like. So, general shifts are usually 8 a.m. till 5 p.m. where I'm working, but you can also have your 12.5 to 13-hour shifts, which are quite long. So, for example, I might have the Monday off, and then on Tuesdays, I might be in theatres all day assisting. So, from 8 till 5, you'll be on the emergency list of whatever comes in. So, the kinds of things that they'd let me do supervise to say someone's got an abscess and it needs draining. The anaesthetist put them to sleep, and then I scrub up with someone supervising me, and I can go and drain that abscess, which is very satisfying. Think Dr. Pimple Popper, but the patient's asleep and there's a lot more pus. You also get to scrub in and help on things like appendectomies or open abdominal surgery, so your laparotomies. So I really enjoy the days that I'm able to be in theatre, even if being a surgeon is not my ultimate aspiration. I think it really helps me kind of understand what I'm doing on my anatomy and my patients. So the next day you might be part of a multidisciplinary team meeting. So say they've got patients with colorectal cancer that need discussing, you join in on that mainly for your learning. And then the afternoon might be a study day. And then we get to the on-calls. So Friday, Saturday, Sunday. So during 8 till 5, the ward is relatively well staffed, relatively. So you'll have colleagues around that you can ask questions to, that you can divide the work with. But then after 5 o'clock, between about 5 and 8:30, you're pretty much by yourself in terms of doctor-wise. So these Friday, Saturday, Sunday shifts are a bit of a killer because you end up with a lot of patients and quite a few of them are very sick and there's only one of you. So that's where it comes to learning about how to prioritize jobs, what needs to be done immediately, what can wait, and actually how you do those jobs, which is what we're going to talk about in the rest of the talk. So what is the role of a resident doctor, for example, on general surgery? So my day-to-day job involves in the morning, we'll meet and have a meeting and we'll go through our patients list and then we will split ourselves up and do our daily ward rounds. So we'll see the patients, what their current issues are, make a plan and write in their notes. After we do all of that, we then go and do all of our jobs. So It's also important that we monitor our patients before and after their operations. So making sure that they're making a good recovery, making sure that they're eating and drinking enough. If they're not, do they need IV fluids? Do they need pain relief, which most of them do? And also looking after any of their wounds. It's also very important during the day and out of hours, so on call, to recognize any patients that are becoming more unwell, using what's known as the A to E approach. A lot of my job is prescribing medicines, fluids, and antibiotics. So I used to know a few antibiotics and a few of the doses. Now there's antibiotics that I use all day, every day. So I know the antibiotic, the dose, I know the contraindications, the side effects, blah, blah, blah. So it's because I use it so often, it's in my head. But then you put me in a different specialty and it would take me a while to pick up. It's also really important that you know how to work with other team members because you're working very closely with the nurses, other allied health professionals, and more senior doctors. And as I said, assisting in theatres as well, which is maybe more of the glamorous part of the job, but not necessarily the most prominent part of the job. So, as part of this pre-operation and post-operation care, we also get involved in clerking new admissions. So, clerking means when you see a patient for the first time, you get the bulk of the story and you start to formulate a plan of what do I think's going on, what do I think this patient needs, and how am I going to get that really. So you assess their history, you ask them what's been going on, order any investigations and scans, and then talk to your seniors about it and prepare the patients for surgery. So that might mean taking specific blood, stopping particular medications, making sure they're nil by mouth. And once they've had their surgery, again, the other end is monitoring them for complications. The main ones we worry about are infections, post-op infections, which can happen immediately after, a few days after, bleeding, or ileus, which is where your bowels kind of slow down and stop moving. Another big part of our job is making sure that patients are well enough to go home when we send them home and writing up any of their medicines that they need and a summary of exactly what we've done in hospital so that that patient has a paper record of it and the patient's GPs, are aware of it as well. So other parts of the job is we do lots of paperwork, basically. I do a lot of paperwork, completing documentation. I also do death certificates, so I certify when people have died, and then I go down and write what the cause of death was. I mentioned discharge summaries and referring to other specialties. So are patients that can be very comorbid, by which I mean most patients don't present with just one problem. So it might be that they present with an issue that the general surgeons need to sort, but they also have heart issues that the cardiac doctors need to sort. So it's making referrals and speaking to our colleagues in other specialties to be able to create a holistic plan for our patient. We also get to attend teaching sessions because actually in the pecking order of doctors, I'm at the most baby end of being a doctor. So they're still teaching us and also engaging in audits and quality improvement projects. So an audit is where you look at how something's being done in the hospital, maybe what could be done better, you implement something and you check it again. Another big part of my job, and a reason why communication skills are so important, is that we communicate with patients and their families about concerns, progress, what's been going on. And actually, this is something that I wish we had more people working in the hospital for, because this takes up a lot of time and people have a right and deserve to know what's going on, but often we're so busy with the work that we don't have time to do this. So that's just about my general day to day. So now to talk about an on-call. So what is an on-call? Well, an on-call is really when there's less staffing and you need to manage acute issues outside of normal working hours. So on-call is your evenings, your nights, and your weekends. So your main job there is basically responding to any urgent bleeps, prioritizing the tasks, the flood of tasks that come your way, and escalating, so getting help when you need it. So the main things that I would do in an on-call is I might get a bleep from a nurse saying, "Hello, doctor, I'm worried about my patient in bed for one because blah, blah, blah. Can you come and see them, please?" So I will go and see the sick patients and I'll assess them using an A to E approach. It's also about if anyone's been to theatre that day or a few days before, managing any post-op complications. The most common ones are they're still in pain, can you up their pain meds? And it's Do they have more pain because there's something new happening, or do they have pain because we haven't managed their pain adequately from the beginning? Post-op bleeding and sepsis. So we're going to talk about sepsis briefly. Other things that we get is I might have been asked to chase bloods, or I might get a call from the lab with a critical value and I need to do something about it. Or I might get asked by the nurses to review some of the medicines because the patient needs something that hasn't been prescribed or they think that they're uncomfortable. It's also really important to have a good relationship with your seniors. By that, I mean your senior house officers, your registrars, your consultants, to be able to ask them for help and tell them when you're worried and be able to tell them exactly what you're worried about and what you think you need help with. And then finally, once you finally make it to the end of your shift, being able to hand over to the doctor that's coming on and starting their shift to make sure nothing's missed and you've got a good continuity of care. Okay? So, surviving an on-call, something that's important to know. So really, it's all about prioritization. How can I prioritize the jobs that I need to do immediately versus what can wait? What's life-threatening? Is this patient going to die if I don't do something? And what can wait till later, either later in my shift, the night team, the day team, etc. So it's really important, especially when you're at a more junior end, that you know when to escalate early. So say you go and assess a patient and you're worried about them. You say, okay, I'm worried. I need some more help. And it's knowing how much more help do you need? Do you need another set of eyes and a brain to just talk things through? Or do you need a whole team of people and you need to put out an emergency call or cardiac arrest call? It's important to know how to stay organised. So during my shift, I'll have a list of all the patients that I'm looking after, and it will have a summary of the main things that's kind of going on. So it'll be their name, their age, where they are, what they've come in with, what their scans show, any past medical history, and what we're doing for them. It's also really important to look after myself because on a 12.5 hour shift, we as healthcare workers have been known to not go to the toilet, not eat, not drink, not have a single rest. It's really important that we know, actually, I'm tired. I need to go have a sit down. I need to have my lunch. I need to take my medicines. The other thing is just because you're on call when there's not many other doctors around doesn't mean you're by yourself. So teamwork really matters because you've got lots of other people around, namely the nurses. You will have seniors around even if they're on the phone, and the pharmacists as well can be an absolute godsend. And the other thing you really learn with an on-call is actually how to stay calm under the pressure of this person's really sick and I'm the only one here. What do I do? So it's really important to have a structured approach to assess your patients when common sense has gone out the window and you're just really stressed. So I've kind of talked about a lot of this. So responding to bleeps, there's lots of things that kind of can come in and can be called in, prioritization, your A to E approaches. So what I wanted to talk about was something that you may or may not have seen before. So this is called the National Early Warning Score, and it's something that's used across hospitals in the UK. So it's basically a piece of paper. It's a checklist that was created to help doctors and nurses keep track of how sick and unwell their patients are. And it consists of a few key observations. So it asks the nurses or the healthcare workers that are doing it to track the patient's temperature, their systolic blood pressure, their respiratory rate, their oxygen saturations and how they're getting that oxygen. Is it on room air or do they have nasal cannula or a full mask on? What their heart rate's doing and whether they're alert, middle or unconscious. So this score can range anywhere from a 0 to 20. Patients can be classified as low score when they're in news 1 to 4. You get a bit more worried when they're in medium of 5 to 6, and a high news score of over 7 definitely warrants a review by at least a doctor, if not a senior doctor. So I appreciate it might be a little bit hard for you to see the scoring system, but I actually wanted you to try and calculate the news score for this patient with these OBS. So what we'll start with is this patient has a temperature of 36.5. So if we were to zoom in and look at the news chart, the temperature's right at the bottom. To be honest, I don't know why I've put them in this order. It's just the way that my brain thought to do it. So if we look at the temperature, 36.5 is actually completely normal and gives you a score of 0. So the aim is healthy, happy patients have a score of 0. Unwell patients have a higher score. So a score of 0 is good. They have a temperature of 36, score 0. Systolic blood pressure of 120, that's also normal, score 0. Respiratory rate of 12, very normal, score 0. Oxygen saturation is 99% on air, again 0. Heart rate 70, 0. Level of consciousness alert, 0. This patient most likely is absolutely fine. There's nothing going on with them. We don't need to panic. If something is going on, we can take our time with finding out what's happening. Okay? So here's a second patient for you. I might just give you about 30 seconds to have a look at it. If anyone wants to put their what you've calculated for their new score in the chat or Q&A, that would be great. And if not, I'll go through it together. So I see someone's put in the Q&A, what if someone has a new score below 36.5? So the new score itself is the piece of paper that tells you how well or unwell someone is. If it's the 36.5 tells us someone's temperature. So a temperature of 36.5 is absolutely normal. If their temperature is below 35.5, I would start to worry about hypothermia, so being too cold. But that's a whole other question for someone else. So we've got people saying 1, is this an adult? Good question. Is this an adult? So this actually changes for children. It changes for children because they've got different ranges. So yes, this is for someone over 18. Thank you. So we've got lots and lots of 1s. What is respiratory rate actually measuring? Why is 12 normal? Good question. So if you were to rest your hand on your chest when you're not talking, and you were to count over a minute how many ins and outs you did, a normal amount is about 12 to 20. So if someone is breathing more than that, you might say that they're breathless and their respiratory rate's high, and there's all sorts of issues that can cause that. And if it's too slow, again, there's all sorts of issues that can cause that, but namely drug overdose. So you want to know that someone's respiratory rate is in that range of 12 to 20. Okay. Got a question of what's systolic blood pressure? Good question. So when we measure someone's blood pressure, there's actually 2 readings. So our blood pressure is essentially a sign of how hard our heart is having to pump to get our blood around our body. And if anyone's ever had their blood pressure taken, you know that we put the cuff on your arm and we squeeze it so tight that actually it cuts off the blood supply to your arm for a little while. As we release the pressure and the blood's able to flow through, we can take a measurement of at what pressure the blood starts to flow. We then keep releasing, and we measure the pressure at which there's some resistance to no resistance. So that's a sign of how well our heart is working and, to be honest, lots of different things, but the systolic blood pressure is important because if it's too low, it can be a sign that someone's body is very unwell, that they're in shock. It can be a sign that someone's lost a lot of blood. It can be a sign someone's got infection. And equally the other way, if your blood pressure is too high, there's a risk of you bursting the pipes. So there's a risk of you having a bleed somewhere. So that's why we want to know what someone's blood pressure is. Fine. So we've got lots and lots of 1s. So correct in that your temperature of 38.2 will score you a 1. Your systolic blood pressure will score you a 0. Respiratory rate of 18 will score you a 0. Oxygen sat's 98% on room air, 0. Heart rate of 90, I believe, is also 0. Yes. And the level of consciousness, they're alert. So to those of you that said 1, very good. This patient has a new score of 1. So the only thing that really concerns me about this patient is their temperature. I might say, have they been really wrapped up in lots of blankets and with a hot water bottle? Could you take it again in 10 minutes? If it was still high, I might say, okay, maybe they've got an infection starting. I'll come and see them. Alrighty, so that's a patient with a new score of 1. Now about this next patient. So they have a temperature of 38.2, a systolic, so a higher reading of blood pressure of 85, respiratory rate 26, oxygen saturation's 94%, heart rate 110, and their level of consciousness, they're only responding to your voice. So I'll give you a minute to have a think about that. It's nice to see there's other questions coming into the chat. Very happy to answer them. So someone's put 3, 3, keep going, 3, 11. I will go through what VP and U stand for. Haven't got there yet. 10, 3, 4. Okay, so there's some different answers for this one, and that's absolutely fine. So fortunately, we usually do this on iPads and it works it out for us, but it's a good exercise to still do it on paper. So your temperature of 38.2 scores a 1. Your systolic blood pressure of 85 scores you a 3. So we're already on 4. A respiratory rate of 26 gives you 3 more. Your oxygen saturations of 94% give you a 1. And your heart rate of 110 gives you another 1. Your level of consciousness to just voice is 3. So that to me, if my counting's correct, is a 12. I would have started looking at these obs and alarm bells go off. I'd go, something is seriously wrong here, okay? So what this is saying is this patient's sick, sick, sick. We need to do something about this. If a nurse called me with these observations, I would say, put out a MET call, which is medical emergency team call. What that means is they go pick up the phone and they say, I have an unwell patient in this part of the hospital at this bed. Send the medical emergency team. And that's made up of a group of doctors that respond to emergencies. I'd say, put out a MET call, I'm on my way. I also want you to put oxygen on them and give them some IV fluids. Right, so very good to those of you that got involved. Where's this gone? So something I would worry about with this patient is, are they septic post-operatively? So this is a very common scenario with someone post-op. So say they've had appendicitis, which is an inflammation and infection of the appendix, which is part of your large bowel. Post-op, what can happen is all sorts of things. They can have bleeding, infection, their wound can break down, they can have poo in the wrong places, and it can make them very sick. So sepsis is an illness in which the body has a severe response to bacterial infection, and it can cause things like a high heart rate, low blood pressure, and fever. So it's the toxins produced by the bacteria which cause leaky blood vessels, which can drop your blood pressure. I won't go into it further, but something like this, I'd think, is it sepsis? Is it like, what's going on? I'd be quite worried about them. And when we have patients that are septic, it's good to have kind of acronyms and quick and easy things to remember when we're in a moment of this patient's sick, what do I do? So for sepsis, we do 3 things that we put on them or in them. So we give them oxygen, we give them antibiotics, and we give them fluids. And we take blood and blood cultures, we take a specific blood test called lactate, and we put a catheter in them, which is a tube basically up into the bladder to measure how much urine is coming out, because your kidneys can suffer with this. So let me talk about what an initial assessment is. So this is my go-to when I get to a patient, especially a patient that I don't know, and I need to assess what's going on. So my first thought is always danger. Is there any danger to me or the patient? Because I've been called to see patients before where they're very agitated, they're aggressive, and they're dangerous to me and other members of staff and patients. So if something's dangerous, assess what's going on here. Do I want to get in the middle? Do I need to get some more help or security? So the way that I remember this is Dr. ABCDE. Fairly simple. There's a really good book called The Checklist Manifesto if you want to read about how this was kind of put together. I find it really interesting and it's good to talk about for medical school interviews. So you assess for danger and response, and then A, B, C, D, E. Sorry. So danger, the first step in any emergency is always to make sure you're safe and others are safe. And then you check for the response of the patient. So this is where the AVPU comes in. So is your patient completely alert? Are they alert only to your voice, to pain, or are they unresponsive? So if the person's alert, you'll walk up to them and say, "Hello, my name's Emma, I'm one of the doctors." The eyes are open, they're aware to you, they're following you around the room, they can talk to you. That's fine, that patient's alert. Say someone's in their bed, but then you can gently tap their shoulders or you can ask them louder, "Hello, can you open your eyes?" And if they open their eyes, but they're a bit groggy, you might say, "Okay," and this isn't just waking up from a sleep. This is someone that might be more unwell or maybe on the wrong medications and too high of a dose. So they'll gently open their eyes, and that's them being responsive only to voice. If that doesn't work, you might do things like tightly squeezing their trapezius muscle. So you're trying to cause a bit of pain that isn't going to cause them harm to try and wake them up. And when you do that, you look for any signs of response like movement, moaning, or eye opening. So if the person is responsive and can communicate with you, you can try and get information about what's going on, how they're feeling, and assess their condition. But if you have a patient that is unresponsive, I would categorically ask for help because I don't think there's any one person that should be looking after someone unwell by themselves. You're always better off with a team. So if there's no response, you call for more medical help immediately. So that might look like pulling the emergency buzzer by the patient's bed or asking the nurses or anyone that's around really to put out an emergency call. And it's best in these situations to be really direct. Say, can you put out, in our hospital, it's 2222 call, a medical emergency call. Tell them where we are and I want you to come back. So I might skip through some of these a bit quickly because I actually want you to have a go at prioritizing different bleeps that you might be getting. So when you're assessing someone's airway, it's really important that we look to see if there's any signs of airway obstruction. So the airway is basically anything from the mouth all the way down the trachea into the lungs. If someone is not, if someone has a blocked airway, they are not, if they are still alive, they're not going to be alive for very long unless you sort it out. So you can look at their chest. Can you see their chest rising and falling? Have a listen, your ear down to their mouth. Can you hear any breath sounds? And can you feel anything on your cheek? Can you feel the air moving in and out if you put your cheek near to their mouth and nose? So it's really important the patient positioning here. So any of you that have done basic life support or first aid will know about the recovery position, which is where you roll someone onto their side, kind of like this. You can look it up. There's also simple airway maneuvers we can do to help someone maintain their airway. Like we can say I'm lying down, you can tilt their head up. It just helps open their airway. Or you can do something called a jaw thrust, which is where when they're unconscious, you can push their jaw forward and it will move their tongue out of the way. There's also things you can do like airway adjuncts, which are basically pieces of plastic you can put in someone's mouth or into their nose to help them maintain their airway. So if you think someone's not breathing, basically, for basic life support, what they recommend is that you start CPR. It gets a bit more complicated when you have more training in that they get you to check for a pulse and a few other things, but we'll move on to that. So when you're assessing someone's breathing, you remember how we talked about in our news score the respiratory rate being normal of about 12 to 20. Well, when you look at someone, you can also see if there's signs that they're struggling to breathe. I'm sure if you've ever done a run or exercise and you can feel that, you get the really big, deep inhalation and exhalation. You can see people kind of using the muscles in their neck. You can see their tummy going up and down. So that's a sign that someone at rest might be in respiratory distress. So cyanosis is when someone's mouth and tongue or the rest of their body can start turning pale and or blue and purple because they're not getting enough oxygen. We can look at their respiratory rate, we can look at how deep they're breathing, if they're breathing regularly or irregularly, how their chest is moving, is it expanding equally, or is one side moving and the other one's not? And then we can also get someone's blood oxygen saturations by using a pulse oximeter, which looks like a little crocodile clip that you put on someone's finger. So the way we fix this is if someone has low oxygen saturations, we can give them oxygen. And this is something that you need to look at if you're going to kind of put more complex airway adjuncts in, which is how far someone can open their mouth if you need to intubate them. So some people have a very clear kind of back of their mouth that you can more easily intubate, and some people it's more obstructed. This is more about the anesthetic side if you're interested in it. But what more commonly happens at the beginning if you can't get if you think someone's not breathing for themselves, you can use a bag valve mask. So this is creates a seal around the mouth and the nose, and you use pressure on the bag to inflate someone's lungs. So the next thing we look for is circulation. So circulation is anything to do with the blood and or the abdomen and the heart. So is there any massive bleeding that you can notice? Is there any blood loss? Look at the colour of the person. Are they pink, pale, blue, mottled, or normal colour? The temperature of their hands. How do they feel when you touch them? We can do something called capillary refill time, which is where you press and hold their finger and you see how quickly the blood comes back. That can tell you how well the blood is moving around their body. Their pulse rates, their blood pressure, and the things you can do to help fix this is you can give someone fluids or blood to help them replace anything that they might have lost or any help they might need. If you suspect that there's any bleeding wounds, you can put pressure on it, and then you can get scans and or surgeons to help you fix any of that bleeding. In this same breath, I'd also talk about examining someone's abdomen to see if there's anything going on there. So most of you are probably aware of CPR. I'm not going to do a demonstration of it, but if we're doing CPR, we want to find we want to find our hands on this lower part of the sternum. You lock your elbows straight, putting your hands on top of each other, and you press down firmly using your whole body. So we say that your hands need to be in the middle of the chest, and you want to go about 2/3 of the way down into someone's chest. And the rate is about 120 compressions a minute. So if you sing the song Staying Alive in your head, you won't be too far off. So it's really important when we do CPR to try and minimize any interruptions, because the longer you're not circulating blood around the body, the worse the outcomes. And then we also give compression breaths. So the next bits are, we call it disability, and that's where we look at someone's temperature, their blood sugar, and we look at their reactions. So that's when we look in someone's eyes to check their pupils. And this is again where we can check if someone's still unresponsive or if they've become more responsive. So if someone's too cold, hypothermic, we can warm them up. If they've got low blood sugar, we can give them a glucose bolus. And if they're unconscious, but they're alive, we can put them in the recovery position to make sure if they vomit, there's no risk of them kind of choking on that vomit. And then finally, exposure. You may have done a very good exam, but you may have missed something. So you want to fully expose the person's body and check front to back, top to bottom to make sure that you haven't missed anything. Take care that you don't kind of cool the patient down too much. Try and respect their dignity. And if you're suspecting any fractures or internal injuries, at my level, I try not to do too much to kind of mess with that, because that's above my scope of practice. So let's talk a little bit about what you would do. So you are the F1 on-call on general surgery. You've been working all day since 8 and it's now 5 p.m, the end of the day shift. Your colleagues hand over their jobs from the end of the day shift and you start to make your list of things you have to do in the next few hours. So this is what a bleep looks like. They look a little bit different in different hospitals, but essentially I tend to carry mine right up here, and it will make a very loud noise and a red flashing colour, and then it will come up with a few numbers. What that tells me is somebody is calling me from that phone and I need to call them back. So I then go to a phone, or I can from my mobile phone, dial that number, and that's when I say, hello, it's the F1 on call, how can I help you? So what I wanted to remind you guys is this is the hospital that I work at. It's pretty big. If I want to go from one end to the other end of the hospital, it takes a long time. It can take like 10 minutes to get from one side to the other, to be honest, and that's on a good day if the lifts are working. And this is what it looks like. It's complicated. So say I get a bleep and I am up in A&E and I have to go down somewhere else. It can take a long while. So these are all the logistics you have to think of and things that can slow you down on your job. And then you've got your long walks on the corridors. So these are the jobs that your colleagues have given you. And whilst they're handing over, the lab calls you as well. So whilst you're handing over, the lab calls you and they have a critical value of a patient's potassium of 6.5. That's fairly high. We want to do something about it. So if you've got high potassium, it can cause all sorts of issues, including cardiac arrhythmias. One of your colleagues has also asked you to review Mr. A. They're a patient that was admitted with appendicitis, but they're requiring more oxygen over the last few hours. Your colleagues have also asked you to check the antibiotic gentamicin levels for patients B and C and prescribe accordingly. And then Mr. D is still waiting to receive 2 units of blood. Please can you chase and prescribe the blood? So I just want you to have a think about what you might do with these, what you think's more urgent, how you might go about approaching these jobs. Feel free to put things in the Q&A if you want to feedback. Nothing on this bit yet. So we've got blood first, lab calls first, how serious is a critical value, Mr. D's are the highest priority, D first. Cool, thanks for getting involved. So this is basically up to the doctor on the day to decide what to do. So you might already know a little bit about these patients and what's going on. So I would say I would probably go and look at Mr. A first. Like, why do they require more oxygen over the last few hours? So what can happen is when people have abdominal surgery, they're in a lot of pain. If we don't manage the pain well, it can cause people to take really shallow breaths. And what can happen then is if someone's not ventilating properly, they can get a chest infection. So I would worry that Mr. A has a developing chest infection, and that's when they're needing the oxygen. So I would go see Mr. A. I'd go do my Dr. ABCDE and see what's going on. What I would find is probably that, yes, they've been struggling to breathe more over the last few hours, that they've got a bit of a cough, they're bringing up some green phlegm. Actually, maybe they've been a bit of a smoker in the past. They've got a bit of a fever. When I listen to their chest, I hear some crackles on the right lower side. And I order them a chest x-ray and some bloods, and the chest x-ray shows me that they've got a pneumonia. All of that might take me 20 minutes to review them properly and prescribe them the antibiotics, and then a little bit of time for the chest x-ray and everything else to happen. So me, that is what I would do first. In the meantime, I would also check who is this patient with the potassium value of 6.5? Is it usually high-ish? Has it just shot up all of a sudden? Are we giving them potassium? Have they got issues with their kidneys? It's all these questions that I'd be thinking about in the background, which I appreciate I haven't given you the information of, because when you get these bleeps, often they give you very little information and you have to ask them more questions. Or sometimes people give you wrong or misleading information. But if the lab calls you with a potassium value of 6.5, I'd think I need to do something about that. So I would have a look through their drug chart, see what they're on, see if they've got any kidney disease. And I would prescribe them the right medicines to help bring down that potassium. And I'd call the ward that that patient is on to let the patient's nurse know and say, please, can you initiate this management for the high potassium? I'm going to come and check on them in an hour and a half. Can you do their bloods again after you've given them the treatment, please? Thank you. And that's kind of something that's urgent, but being dealt with in the background. Then I would make sure that I've called the blood bank for Mr. D's blood. So I'd call the blood bank and say, hello, just checking that we've still got these 2 units of red blood for Mr. D. When will it be ready? When can we send someone down to get it? They'd tell me and I could prescribe the blood and let the nurses know. And then finally, checking the antibiotic levels. This is something that can take a lot of time because you need to give the antibiotic and then you need to take the bloods a certain number of hours after. And then it takes a while for the blood results to come back. And then you have to do some calculations to see when they can have the next dose and how much. So they need to have their antibiotics, but if it's delayed by an hour or two, it doesn't really matter. It won't really affect them. Okay, especially if they're not seriously unwell. So that's what I would leave for last. But thank you for getting involved and giving your opinions. So there's some more bleeps for you because an hour and a half has passed and you get some more. So a nurse from level 8 of a different building has called you to say that your patient, Mr. CG, who was having end-of-life care has died and they'd like you to verify the death. And then a nurse from level 9, again in a different building, has bleeped saying they're worried about Mrs. RH, who started spiking temperatures of 38.5 and is more confused than usual. She'd like you to review them. Any ideas, any contributions as to what you do for this and why? There's no right or wrong answer. We can just discuss why. So we've got RH first, level 9 then 8. Cool. Yes. So I would agree with generally what you guys are putting. So I would be more worried about this patient on level 9 because they've got a temperature and they're more confused. So again, I would go over and I'd say, I'd say, can you tell me a bit more about them? Like, do you know why they're here? What are they usually like? Are they usually confused? I would go over, I'd look at their news, see are they scoring highly on anything else. I'd probably read through their medical notes and see why are they here? Have they had an operation? What medicines are they on? What's their background? Do they have any past medical history I should know about? And I do my A to E. So once I've done my A to E and I've established what I think's going on, generally I can start the management myself, but often it's not that simple. So I might go down and I might call my senior and just say, hi, I've got this lady up on level 9. This is what I found. This is what I'm worried about. Do you agree with my plan? And they might say, yes, that's fine. Or no, add these things. Or have you thought of this? Or actually, I'm worried about them too. Let me come and see them with you. So it's all about telling someone how worried you are and how much help you need. And then, yes, so it is important to verify that someone has died. However, because they are not, it's less of an urgent job because the death was expected and there are other patients with more clinical need with more time pressure, really. So you'd go do your other jobs and then you would go verify the death. If you didn't have time to do it by the end of your shift, it's definitely something you would pass on to the night doctor. So you would go to the ward, you'd find the nurse and the patient, maybe read a little bit about what happened, because often you don't know the patient at all, you've never met them. For example, in general surgery where I work, there's 120 patients. There's no way I can know every single patient. So I would look after about 60 of them in the evenings on call, and I'd have another colleague looking after about 60. We're so busy, we rarely see each other. If we need anything, we can call and be like, hi, I've got this going on. What do you think? But we're so busy, we rarely see each other. So again, I might not actually know this patient myself, so I'll read up a little bit about what's going on with them, and then I'll go in and verify the death. So once I've verified the death, you need to do your writing down what you've done for legal reasons, and then either you or a doctor the next day can go and write their death certificate. Okay? So that is the end of my talk about being a new resident doctor on general surgery, and being on call. So I just wanted to give you the opportunity to ask any more questions. Feel free to ask me about what being a resident doctor's like, medical school, what admissions is like, my experience, and any personal experiences or tips. And thank you guys so much for listening.
Thank you so much, Emma, for that really brilliant talk. There's been loads of questions in the chat, so maybe I can just pick out a couple for us to answer, if that's okay
Yeah,
with
of
you.
course.
Brilliant. Okay. Um, just quickly, quite a few people just wanted to check in about the title of the book that you
Yeah, of course.
mentioned.
The book I'd recommend is called The Checklist Manifesto. There's quite a few books by Atul Gawande that I think are really good. But the Checklist Manifesto is one that I particularly enjoyed. So he is a surgeon who was hired by the WHO, the World Health Organization, to look into how they could reduce surgical deaths. And it basically meant that they went looking for ways that we could reduce errors in surgery and medicine, and they went looking at other industries. So they went and looked in the aviation industry and found that they do lots and lots and lots of pre-flight checks with checklists to reduce the number of errors they made. They also went into mass kind of architecture and building and found how is it that you build these massive buildings and nothing goes wrong? checklists. So it's how they kind of developed that and its application to medicine. Yeah.
Brilliant. Thank you, Emma.
You're
Um,
welcome.
we also had quite a few people asking about when you're doing your foundation year one, how
Yeah.
the rotations and also the location is kind of allocated. Could you talk about that a little bit?
Of course. So it recently changed. It used to be that you would do your exams at medical school, and depending on how well you did, you were kind of given a ranking. So you were in the top 10% or 20 or 30 or 40 or 50, etc. So they used to combine that with an exam that you took called the situational judgment test. And with that, they'd give you a ranking. And if you had a high ranking, it meant that you were likely to get your preference jobs. So the most competitive jobs were always in London and for surgery. And they would kind of rank it that way. But in the last 2 years, they've actually changed it. So they use a random number generator to give you a number, and you might be given number one or number 10,000. And if you're given number one, you're likely to get the location and the job you want. And if you're given number 10,000, you're probably going to end up somewhere far away in a job that you didn't really want to do. I kind of sidestepped that and I applied for something called the Special Foundation Program, which meant that I had a bit more autonomy over where in the country I ended up and what jobs I did. But it did require quite a lot more planning and application. So you had to prove teaching and research experience and publications and blah, blah, blah. So it was a little bit harder. So that's how they decide it. But you have a little bit of say over where you are in the country and what jobs you do, but unfortunately not a lot. And actually, that's one of the harder things I would say about being a doctor to definitely consider, because it is a national health service and they do need doctors everywhere. That doesn't necessarily mean the doctors want to be there, which sounds really bad, but yeah, it's just not nice to not have autonomy over where you're going to live.
Yeah, absolutely. Thanks, Emma.
Yeah,
Um, so a couple of people also asking about, so obviously working an on-call shift is can be really draining, like physically and emotionally. People are asking how you kind of both prepare for that and how you deal with that when the shift is over, and
yeah,
do you have time for like a social life and family and things alongside being
yeah.
a doctor?
Yes, that's a really good question. I would say the way I prepare is usually you have at least a day off after your on-calls to kind of recover. And you know that it's coming. So the kinds of things I do is I make sure that most of my laundry's done. I make sure I've got some food at home, food prep. I make sure that I've slept. I make sure that I've packed myself like a lunch and some water and some snacks, that kind of thing. And then just being really firm with taking your breaks. And for example, during the day, I try not to carry the bleep because I know that in the evening I'm going to be carrying it and it's going to be going off like crazy. So trying to kind of divvy up the workload that way. In terms of looking after yourself in a wider sense and socializing, some weeks are absolutely brutal in that I've done like 80-hour work weeks and I'm like, I can't even see straight. When I think the full-time working in the UK is what, 36 and a half hours. So we're doing more than double that, which is crazy. But then the next week you might only do 20 hours. So it evens out a little bit. So you can work less than full time, and actually they're making it a lot more flexible for that, which is really good. And it's something I'm considering doing next year, just because this year's been really intense. You do tend to make friends with the people you work with because you spend all day with them. And you see some pretty intense things, so you have to like bond with them to get through it. In terms of keeping up a social life outside, what I've found hard is often like I'll have a random Wednesday off and like all my friends are working and then I can't kind of see them. So it's kind of a day where you're like, okay, well, I guess I'll go to the gym or like do some food shopping or go to a cafe. So it can be a bit lonely in that sense, but it's not a bad job, and you do have time for other things. It's more the lack of energy, to be honest. Like, I find that I'm really tired and I sleep a lot, like a teenager.
That sounds fair enough. It sounds really, really busy. Um, we've had also had quite a few questions about how you found relevant work experience, which I think is a great question. And I can also jump in a little bit about how we think about how we view work experience and stuff at BSMS, but it'd be great to
Yeah.
hear your experience, Emma.
Yeah, so what I did for work experience is when I was 14 to 18, I did St John's Ambulance. So I learnt first aid and I went to kind of public events to help deliver first aid and I taught first aid. So it was quite a good way to kind of step into that healthcare type role and learn to work with other people and what it's like to talk to people that are struggling or in pain or in an emergency situation. I also worked in a shop. So I worked in a bra shop fitting bras, and again, that's something that taught me communication skills and how to be kind of empathetic to people. Um, and yeah, just kind of problem solving and dealing with angry people because you'd get angry people, which is fine. I also volunteered on a hospital ward to kind of get a flavour for hospitals. I did some tutoring. Notice how most of this isn't actually medical. So what I'd like to say is I think it's become really, really hard since COVID to get any kind of healthcare work experience, because they've really tightened up their policies. So I can't speak for all medical schools, but my impression is that they don't really care what work experience you've done, as long as you can say what you've learnt from it. So as long as you can say, I worked in a shop for a year and it meant that I had to work on my problem solving and communication skills, especially dealing with members of the public. They'd much rather hear about that work experience than I shadowed this cardiothoracic surgeon in a hospital for a week, full stop, and you can't say anything about it. So I wouldn't worry too much about the healthcare side. Um, what I would say is that you can do some online and virtual work experience as well. So um, I know this because I went to BSMS and I helped set this up. They've got a virtual work experience. The Royal College of GPs also has a virtual work experience, so that can kind of give you a flavour for healthcare settings and the NHS without actually having to find a placement. If you can find a placement either in a hospital or in a GP, that's great. But I also wouldn't panic if you can't find it because medical schools understand it's really hard to get experience these days.
Yeah, absolutely. I was going to say pretty much the same thing, Emma. I just want to reassure everyone that, yeah, the expectation isn't that you will definitely have clinical work experience. As Emma said, any work experience of engaging with the public is really valuable. Any work experience that involves teaching skills to other people, is really important because of medical education. As a doctor, you have to teach your patients about how to look after themselves, and as exactly as Emma said, it's really about the quality of your reflection on those experiences. How have they helped you develop the skills that will make you a good doctor or a good medical student, and how have they helped you to maybe understand more of those realities of working with the public. And as Emma said, we have a virtual work experience program through BSMS, which you're welcome to participate in. I'll make sure the link to that is in the follow-up email that you'll receive after this lecture. Maybe we've got time for just one more question, Emma, and then
Yeah.
we'll wrap up. I'm not sure if there's any that you saw in the chat that you particularly wanted to answer, or I can choose one.
Um, yeah, why don't you go ahead and choose one? There's some really good ones. I'm like, oh,
There are some really good ones. I wish we had more time for all of them. But maybe a nice one to end on, Emma, is about why you actually wanted to be a doctor in the first place.
yeah. So I think there's the short version and the long version. The short version is I like helping people and I like problem solving. But the long version is I was always interested in sciences and I was very sociable and liked other people. I thought I wanted to be a vet. And then I realized being a vet was a lot of putting animals down and I didn't like that. So I kind of got interested in medicine and doctors and how I could help people. Then I got cancer when I was 14 years old, and it actually made me think, wow, maybe I really want to work in a hospital. And initially I thought I wanted to be a nurse because the people that I felt had made most of an impact on me had been nurses. So I started looking into nursing and what that was like and how I could do that. But actually, the more nurses I spoke to, the more they said, actually, Emma, if you're really interested in the science of it all and in kind of pushing yourself with your brain, and your problem solving skills, maybe you should consider medicine, maybe you should consider being a doctor. And they said the only kind of progression they could have as nurses was into management roles, and actually that's not why they became a nurse. And that there was a lot of kind of extra courses they had to do to prove that they had skills that they already had. So I thought about pharmacy because I liked medicines and I always had good interactions with pharmacists. But actually, I thought being a doctor would probably be the route that would allow me to do the most with my skills and my experiences and help the most people. So what I say now is I'm a doctor, but I try and have the empathy of a nurse because really the nurses are the ones that helped me the most when I was ill. So that's the long version of why I want to be a doctor. I'm really interested in cancer and in widening participation because I came from a less traditional route. I went to a state school. None of my family are in healthcare. So that's kind of why I'm interested in medicine and in helping others. So yeah, that's why I want to be a doctor, and I still really enjoy it. But being a doctor on the oncology ward when you've had cancer yourself and your family's had cancer is really hard. And I guess that's something else to think about. We've all got our own experiences of illness, and actually, you're working with people in a really personal way. So it's how do you look after yourself and how do you bring your experiences to help other people as well without burning yourself out? So yeah, that's the long answer and probably more deep than you were expecting, but that's the reason.
Thanks so much, Emma, for sharing that with us. That's really brilliant. And thank you again so much for your fascinating talk. I really enjoyed it, and I want to give you a big round of applause on behalf of our 215 participants that we've had with us. So thank you again so much, Emma. Thank you, everyone, for attending our talk this evening. We'll hopefully see you next time. I can see lots of thank yous coming into the chat as well, Emma. So
Thank you
that's really
guys.
great.
Thanks for engaging. Sorry we weren't able to get to all the questions. But my advice is if you see any healthcare workers, whether they're doctors or nurses or pharmacists or physios, just ask them what their job is like and ask them what they like about it and what they don't and what they regret and what they would do differently, because I think you'll learn a lot. And you don't have to be a doctor, is the other thing I would say. So yeah.
Brilliant. Thanks so much, Emma. Thank you, everyone. I'm going to stop the recording of this meeting now and end it. So all take care and have a lovely evening. Bye, everyone.
Bye.